All right, let's dive into something that's honestly a true marvel of modern medicine. We're talking about the art of turning consciousness off and then, reliably, turning it back on again, almost like a light switch. We are going to explore the absolutely fascinating world of inhalational anesthetics. I mean, just think about that question for a second. At its very core, this is the incredible puzzle that anesthesists solve every single day. It's not just sleep. It's a carefully controlled, totally reversible journey into unconsciousness. And the agents that make it all possible, well, they're masterpieces of pharmacology. So what are we really talking about here? Well, these are volatile agents, basically gases or liquids that turn into vapors really easily that you just breathe in. And their entire job is to create a very specific, very temporary state that makes surgery possible and, completely painless. And it's so much more than just being asleep. These powerful agents are designed to hit 4 key targets. First, of course, is a reversible loss of consciousness. Second, analgesia, which means you feel zero pain. Third is amnesia, so you have no memory of the procedure. And finally, muscle relaxation. This one is absolutely critical so the surgeon can actually do their job effectively.
Okay, so how on earth do a few puffs of gas accomplish all of that? Let's get into the incredible science behind this controlled sleep. This is honestly the best way to think about it. It's like a master volume control for your brain. The anesthetic basically does 2 things at once. It cranks up the volume on the brain's quiet down signals, that's mainly through receptors called GABA-A, and at the same time, it turns down the volume on all the wake up or pay attention signals, like the NMDA receptors. It's this 2-pronged attack that safely guides the brain into unconsciousness.
But here's the thing, not all anesthetics are created equal, not by a long shot. And to really get how doctors choose the right one, we need to look at the 2 stats that matter more than anything else, how strong they are and how fast they work.
First up, let's talk about potency, or, its strength. The way we measure this is with something called the minimum alveolar concentration, or MAC for short. It's the gold standard, really. It defines exactly how much of the gas you need in the lungs to prevent half of all patients from moving during a surgical incision.
Now this is the key point, and it can feel a little backwards at first, so stick with me. A low MAC number means the drug is highly potent. It means you don't need a lot of it to get the job done. A little really does go a long, long way.
And this shows that idea perfectly. On one side, you have halothane. It has a low MAC, which means it's super potent. On the other end of the spectrum, you have nitrous oxide. Yep, laughing gas. It has a really high MAC, meaning it's actually a pretty weak anesthetic all by itself. That's why it's often used more for pain relief alongside other, stronger agents.
Okay, so that's potency. Now for the second critical number, speed. This is all determined by something called the blood-gas partition coefficient. It sounds complicated, but all it really tells us is how much the anesthetic likes to dissolve in the blood compared to just staying as a gas in your lungs. And that single property, its solubility, is what controls how fast it gets to the brain and, just as important, how fast it gets out. So, the rule of thumb to remember is simple. Low solubility equals fast. If the agent doesn't dissolve much in the blood, it doesn't linger or get stuck there. It just zips from the lungs straight to the brain to put you to sleep, and when the gas is turned off, it zips right back out for a super quick wake-up.
And this chart right here shows us the modern-day speed champions. Agents like Sevoflurane and Desflurane have incredibly low solubility. That's why they are famous for their fast onset and, maybe even more importantly, for letting patients wake up really quickly and clearly after their surgery is done.
Okay, now that we get potency and speed, we can finally meet the agents themselves. And really, the best way to think about them is like a team of specialists, where each one has its own unique personality and its own special skills.
This table is basically the ultimate cheat sheet. You can see everything we've talked about all in one spot. You've got nitrous oxide, fast but weak. Halothane, really potent but slower and comes with some safety issues. Isoflurane is like the reliable workhorse, potent, stable for the heart, but it has a really strong smell. Then you have the modern speedsters, Sevoflurane, which is fast and not irritating, and Desflurane, the fastest of them all, but it can be a bit harsh on the airway.
Let's zoom in on Sevoflurane for a second. Its profile makes it the smooth inducer. Because it doesn't have a nasty smell and it's not irritating to breathe in, it is perfect for gently sending a patient, especially a nervous kid, off to sleep without any distress. It's a game changer for pediatric anesthesia.
And then you've got Desflurane. that we could call the fast finisher. It's got that unbelievably low solubility, which means patients can wake up and feel alert almost immediately after the procedure. This is a massive advantage for outpatient surgeries, but the trade-off is that it can be irritating to the airways when you're first going to sleep.
And we have to give a nod to Halothane. It was the potent, problematic original. I mean, it was a total game changer, providing super smooth inductions. But over time, we discovered some serious risks, like making the heart extra sensitive to adrenaline, and in some rare cases, even causing liver damage. That's why you don't see it used as much today, now that we have agents with much better safety profiles.
So, with this whole toolkit of different agents, how does an anesthetist actually make the call? Well, it all comes down to a really careful balancing act. And here's maybe the single most important takeaway from all of this. There is no single best anesthetic that works for every person in every situation. The choice is always a highly strategic one, and it's tailored specifically to the individual patient, their health, and what the surgery actually requires. And this is a peek into how they think it through. First, they're going to assess the patient's safety profile. Do they have any heart or lung problems? Second, what does the surgery need? Do we need a really fast wake-up? Third, they match the drug's potency to how intense the procedure is. And finally, they weigh the unique quirks of each agent, like whether that pungent smell or airway irritation could cause a problem. It's a complex, multi-layered decision every single time.
So when you step back, it's pretty incredible. We have developed this amazing ability to reversibly turn off a person's awareness, their memory, their perception. It's a massive triumph of science. But it leaves us with this final, much deeper question. As we get better and better at controlling consciousness, what does that teach us about the fundamental mystery of what consciousness actually is? Something to think about. Thanks for tuning in.